Welcome back for DVD 2 of our presentation, Testosterone, the Heart Hormone for Men. My name is James Roberts. I'm board certified in internal medicine and cardiology. I've been practicing invasive, clinical, and now integrative cardiology in Northwest Ohio over the past 23 years, and I'm the medical director of comprehensive heart care, the Enhanced External Counterpulsation in Northwest Ohio, the Advanced Magnetic Research Institute of Northwest Ohio, and Total Body Balance Medical Weight Loss Center. This section focuses on the clinical studies demonstrating the benefits of physiologic testosterone replacement therapy in men with congestive heart failure. Now, congestive heart failure is due to myocyte dysfunction. Myocytes are heart cells. We can have many different causes of congestive heart failure. There can be loss of myocytes due to a heart attack. There can be dysfunction of myocytes due to viral myocarditis. There can be excessive strain on the heart due to high blood pressure or valve disease. But the remaining heart cells will be strained. We have myocyte dysfunction. And the first thing that goes wrong is the heart becomes stiff. It doesn't fill well. We call this diastolic dysfunction. This is followed by impaired pumping function, a reduction in ejection fraction. We call this systolic dysfunction. Common to all forms of heart failure will be decreased forward pulsatile blood flow from the heart. So there'll be decreased delivery of oxygenated blood to the tissues. The body cries foul. It is quite unhappy that it's not getting enough blood and oxygen. And the body responds in a fashion that is appropriate for cave people. Forward blood flow in cave people would be compromised not by heart disease. We didn't have heart disease when we were cave people, but by the stresses that primitive man might experience. Primitive man's forward blood flow would be compromised if he was dehydrated, or if he had a blood loss anemia, or if he had an infection and his blood pressure and blood flow was low. So our physiology has not evolved from that of a successful cave person to be a successful cardiac patient. So our body's response to heart failure and impaired forward blood flow is maladaptive, and this neuroendocrine response aggravates the heart failure. This is why heart failure due to any cause tends to be a progressive disease. Even if the original cause of heart failure is stabilized, because the body's response is maladaptive, you're going to cause more myocyte dysfunction and progressive decline in health. Now, the kidney senses poor blood flow, so it thinks, gee, my human must be dehydrated. So it releases a hormone called renin that leads to upregulation of a hormone called angiotensin II that causes vasoconstriction. Well, that will raise your blood pressure, but it also strains the heart and whips the heart. The adrenal glands, they see poor blood flow, they say, gee, dehydration, they release a hormone called aldosterone that causes sodium retention and makes the heart stiff. That's great if you're dehydrated, but it's bad if you have heart failure. The autonomic nervous system knows something's wrong, so it responds with a sympathetic outpouring of adrenaline and noradrenaline, whipping the heart and constricting the blood vessels. Modern day therapy for congestive heart failure is neuroendocrine blockade. We will block angiotensin II generation with ACE inhibitors. We'll block the effects of aldosterone with an anti-aldosterone called spironolactone. We'll block the upregulated production of adrenaline and noradrenaline with beta blocker therapy. We can blunt the maladaptive response and prevent the progressive deterioration in functional status that used to typify congestive heart failure. Now, when I was training back in the dark ages, if you had congestive heart failure, we'd give you water pills and a drug called digoxin that makes the heart function a little bit better. And this didn't work very well. And the 1-year mortality rate for heart failure was 50%. When we learned about these ACE inhibitors, we could block one of the maladaptive whips. Yearly mortality from heart failure fell to 36%. When we added spironolactone, it falls to 18%. If we add beta blockers, it falls to 12%. So when I trained, the 1-year mortality was 52%. Now with neurohumeral blockade, it's down to 12%. But this is not complete therapy. It is not an appropriate solution if we want to practice integrative cardiology. There are a number of pathophysiologic mechanisms mediating heart failure and coronary ischemia. We want to blunt all of them. So we have the problem with myocyte dysfunction, the inappropriate neuroendocrine response. It also turns out that the overworked, chronically whipped heart runs out of the molecules it needs to generate energy. The workers on the energy production assembly line drop out. If we biopsy your heart and you have heart failure, you're going to be low in magnesium, taurine, thiamine, carnitine, and coenzyme Q. And if we supplement you and replenish these molecules in your heart will respond by improving functional status. So there's a great role for nutritional supplementation in heart failure. We have several DVD presentations on that you can review. Now, with respect to testosterone therapy, the immune system upregulates in heart failure just as it does in coronary disease. And testosterone downregulates this maladaptive immune response and thus helps in heart failure. Catabolic anabolic imbalance. Heart failure is a fight or flight situation. You make cortisol, which is catabolic. You break down, you become cachectic, you become wasted. Testosterone levels are low, cortisol levels are high, and it will present some studies showing that this catabolic anabolic imbalance can be rectified with testosterone therapy. So we are going to take a choice E, all the above approach to help our patients with congestive heart failure, and this works pretty well. Here's a patient that presented to me a day and a half into a large heart attack, and her heart looked awful. It was a disaster. She did not want to go to the hospital, and she was 80 years old and would have been a poor candidate for an urgent heart catheterization and a bypass or a stent. And anyway, she wouldn't let me put her in the hospital. So I put her on all the drugs known to be helpful in heart attack. I put her on all the nutritional supports that were helpful in heart attack. Because she's a woman, I didn't give her testosterone, but I used other immune modulators. 9 months later, she has a normal heart. We used all of our therapies, including some regenerative therapies, some stem cell stimulating therapies, and when we take this integrative approach, we get our best results. Now, so when we're treating heart failure, we can use drugs, we can use devices, we can use nutritional support, and we have DVDs that cover this. And in this section of our presentation, we'll discuss the studies showing benefits of testosterone in heart failure. First, let's look at hemodynamics. We showed that intracoronary testosterone dilates the coronary arteries. Let's see what happens to the tone of the systemic arteries, the rest of the arteries in the body, in response to testosterone. We're going to take 12 men with heart failure. Their ejection fraction is 30%. Ejection fraction is the percentage of blood the heart ejects with each beat. Normal is 50%, 30% is pretty significant pump dysfunction. We're going to hold all their vasoactive medications, and we're going to put in a right heart catheter, and then we're going to do baseline hemodynamic measurements and randomize them to receive buccal, or like a sublingual patch of testosterone or placebo, and then we're going to repeat the measurements over the next 6 hours. And what you find in response to the buccal testosterone, their levels will go up. Nothing happens with placebo. Cardiac index, or cardiac output, falls over time following the catheter placement. Now, why is this occurring? When we put in these central lines, it hurts you a little bit, and you also know that if we mess up, we can hit the artery or puncture your lung. So you're going to be a little bit tense, and your adrenaline levels are going to be high, so your cardiac output is going to increase. Over time, as you relax, it will fall, but not with testosterone therapy. It improved cardiac performance. Systemic vascular resistance rises over time with placebo therapy. Your arteries tend to constrict as your epinephrine levels fall. That did not happen with testosterone. So the treatment effect, testosterone increases cardiac output and lowers systemic vascular resistance. It dilates peripheral arteries just as it dilates arteries in the heart. If we dilate our peripheral arteries, the heart can pump forward into less resistance. It's sort of pumping into a vacuum, so cardiac output will increase. Testosterone, TNF, and heart failure. Now, congestive heart failure is an inflammatory state. Pro-inflammatory Th1 cytokines are elevated, similar to the situation in coronary disease. Androgen levels are typically depressed. Tumor necrosis factor, TNF-alpha, is an inflammatory cytokine. High levels of TNF-alpha are associated with a poor outcome in heart failure patients. We know that testosterone downregulates the production of inflammatory cytokines in coronary disease, and indeed it will downregulate the production of inflammatory cytokines in patients with heart failure. Will testosterone blood inflammation and improve functional status in patients with heart failure? We'll answer that question, but first I want to explore the relationship between anabolic catabolic status and functional status and survival in men with heart failure. 208 men with heart failure, mean age 63, their mean ejection fraction is 33%. You'll measure their anabolic, their building hormones, testosterone, free testosterone, DHEA, sulfate, that is an adrenal anabolic hormone. IGF-1 is a measure of growth hormone, which is anabolic. You'll define deficiency as levels in the heart failure patients below the 10th percentile for age-matched controls that did not have heart failure. We'll determine the prevalence of anabolic deficiency amongst the heart failure patients. We're going to follow these heart failure patients for 3 years, correlate 3-year survival in the men with heart failure against their baseline anabolic hormone status. Now, amongst the men above 66 years of age, the controls in blue have higher levels of free testosterone, DHEA, and IGF-1 than do the age-matched heart failure patients. That makes sense. Heart failure is inflammatory. It is catabolic. Let's look at the prevalence of deficiency of the anabolic hormones in the men with heart failure. Now, free testosterone levels were quite low, 60% and 40% in the youngest men below 45 with heart failure and the oldest men, 20% in the middle-aged men. But the prevalence of deficiency in DHEA and IGF-1 was about 60% in the men with heart failure. Now, if we look at the relationship between levels of anabolic hormones and functional status, the men with New York Heart Association Functional Class 1 had higher testosterone levels than men with functional class 2, 3, and 4. Now, class 1 is good. You can't play tennis, but you're leading a pretty good life. Class 4 is you're short of breath at rest. You're on death's door. So the more severe the heart failure, you see lower baseline levels of testosterone, free testosterone, DHEA, and IGF-1. That makes sense. Now, let's look at the relationship between your anabolic status at baseline and your 3-year survival. Men that were not deficient in any of the anabolic hormones had a low death rate or a high survival rate. Men that had one anabolic deficiency as compared to men with none were 64% more likely to die. Men with 2 anabolic deficiencies were 3.4 times as likely to die. Men with deficiencies in all the anabolic hormones were 7.7 times as likely to die. So low anabolic status, high catabolic status is associated with poor functional status in patients with heart failure and a poor prognosis, a poor outcome. Testosterone and VO2 max. 43 heart failure patients who survived 2 years, their testosterone level was 488 at baseline and it fell to 399 at 2 years. That's not a surprise. Their free testosterone levels fell dramatically from 11.5 to 6.2. VO2 max, which is a measure of maximal oxygen uptake with exercise, that is a measure of the fitness of your mitochondria, the ability to generate ATP energy from sugar and fat. It is the best measurement of aerobic function and clinical status. It fell over time And the decrease in testosterone correlated with the decrease in the VO2 max. So testosterone levels fall in lockstep with metabolic fitness. You need testosterone for your mitochondria to function normally so you can generate energy from sugar and fat. With heart failure, testosterone levels fall, mitochondrial function falls, functional status and outcome will deteriorate. Impaired peak VO2 max, exercise capacity, is a hallmark of heart failure. It's associated with a poor prognosis, correlates with low ejection fraction, diabetes, anemia, kidney dysfunction. The lower your testosterone, the greater your age, the lower is your VO2 max. BNP, B-type natriuretic peptide, is a protein released by the heart in response to stress and strain. The higher your BNP, the worse your heart failure. The higher your BNP, the lower your VO2 max. So this VO2 max is a very important parameter. Now, let's look at a study of transdermal testosterone in men with heart failure. 76 men with chronic heart failure, they have pump dysfunction, their average ejection fraction 32%, stable symptoms for 6 months, their mean testosterone level was 13, only 24% were hypogonadal. They were not selected for low testosterone, they were selected for heart failure, and 24% had low testosterone levels, as one would expect. You do a baseline study, randomize them to receive the androderm testosterone patch or placebo. All prior medicines were continued. You reevaluate at 1 year. A double-blind protocol was followed. Testosterone and bioavailable testosterone do not rise in response to placebo. Of course, they rise in response to the testosterone patch therapy. How far you could walk in 6 minutes. This is called the incremental shuttle walk test. It's a standardized marker of functional status in heart failure. There was a deterioration in the placebo group and an improvement with testosterone therapy. The greater the rise in testosterone, the greater was the incremental improvement in functional capacity. All the men improved, but those with lower baseline testosterone levels improved the most. Here's a study of intramuscular testosterone in men with heart failure. 20 men with heart failure, mean age 61, ejection fractions 37%. They were not selected for low testosterone status. Many were hypogonadal, but they were selected as typical men with heart failure. You do the baseline studies, randomize them to receive intramuscular testosterone, 100 milligrams every 2 weeks, or placebo therapy. All their prior meds were continued. Their increase in walking distance was 91 meters. So here we have the change in incremental shuttle walk test with transdermal testosterone. Here we have the change with intramuscular. You really shouldn't compare different studies, different patient populations, but the intramuscular testosterone therapy achieves a higher and more stable blood level than does the topical, and you got a relatively greater improvement in functional status. Another study, 64 elderly men with heart failure, 30% are hypogonadal, mean ejection fraction is 40%. You do a baseline study, baseline measurements, and you randomize them to receive intramuscular testosterone undecanoate, 1,000 milligrams every 6 weeks for 3 doses, or placebo. Now, these men were on modern day medical therapy, 86% on beta blockers, so they're on the maximal medical therapy that pharmaceutical medicine has to offer. One group receives testosterone plus optimal medical therapy, the other gets a placebo. And you reevaluate at 12 weeks. Testosterone and free testosterone levels improve, insulin resistance falls, as you'd expect. Baroreceptor reflex. This is a measure of autonomic function. Heart failure is associated with autonomic dysfunction, high sympathetic, low parasympathetic. This increases your propensity to arrhythmias. This tells us that testosterone modulates the autonomic nervous system, brings sympathetic to parasympathetic back into balance. Peak VO2 max increases. How much work you could do, peak workload on the exercise bike increases. Quadriceps, your thigh muscle strength improves, and how far you could walk in 6 minutes also improves. Now, all the men demonstrated an improvement in quadriceps muscle strength, The men with low testosterone levels improve the most. If you look at rate of improvement or level of improvement in muscle strength, the lower your baseline testosterone, the greater is the benefit. Similar situation with mitochondrial function, peak oxygen uptake. All the men improve, but the men with the lower testosterone levels improve the most. Testosterone and inflammation in experimental heart failure. 100 sexually mature male rats. In 85, you're going to ligate the left anterior descending coronary that serves the front wall of the heart and create a massive heart attack. And half of the animals did not survive. But 44 of the 85 were still alive at 6 weeks with poor pump function and heart failure. You do sham surgery on 15, they have normal hearts. You do baseline measurements at this point, randomize them to receive over 12 weeks, intramuscular testosterone every 2 weeks or placebo, and evaluate their status at 12 weeks. Now, testosterone levels in the animals that did not have an experimental heart attack, they had sham surgery, were stable. Those that had the heart attack, at baseline, they have a normal testosterone level. In response to the heart attack and pump dysfunction and heart failure, their testosterone levels fell, and at 18 weeks, they continued to fall because heart failure is associated with ongoing inflammation, testicular dysfunction, testosterone levels will fall. Now, if you take the animals that have the heart attack, their testosterone levels fall in response to the heart attack, but if you treat them with testosterone, their levels will rise. Now, body weight increased in the healthy animals that were not subjected to a heart attack. Those that experienced the heart attack, body weight did not increase, their growth was stunted, and with placebo therapy, nothing happened. Growth was stunted in the animals that had the heart attack, but if you give them testosterone, which is anabolic, growth improves towards baseline. Serum tumor necrosis factor alpha is high with experimental heart attack, and it doesn't change with placebo, but it does fall with testosterone. Myocardial expression of messenger RNA for TNF. That means that you're changing the reading of DNA in the heart, not elsewhere in the body, but indeed in the heart. So in response to an experimental heart attack, and presumably a clinical heart attack in humans, protein formation, DNA reading in the heart is changed by the inflammatory mediators, and you're making TNF in the heart. And this is downregulated by testosterone. IL-10 in the blood, a good guy, falls with experimental heart attack. Experimental heart attack and testosterone treatment, the situation is rectified. Expression of matrix metalloproteinases will increase in response to heart attack and improve with testosterone. Now, in coronary disease, the matrix metalloproteinases degrade the fibrous plaque and make the plaque more likely to rupture. In the situation of heart attack, the matrix metalloproteinases actually degrade the heart muscle, causing the heart to remodel to dilate, which is deleterious. This is blocked by testosterone. Ejection fraction falls in response to the heart attack, and it improves a little bit with testosterone. The improvement in pump function correlates with the rise in testosterone. Mortality at 18 weeks, well, none of the normal animals died. 68% of those that had the experimental heart attack and then received placebo therapy died. Only 32% of those with experimental heart attack who then were treated with testosterone. So clinical effects of testosterone and heart failure, symptoms of heart failure improve, energy levels, sense of well-being, depression improves. This is due to the anabolic and anti-catabolic properties of testosterone, immune modulation, support of autonomic function, and vasodilatation. In the next section, we'll examine the non-cardiovascular clinical benefits of testosterone. To this point, we reviewed testosterone physiology and studied the effects of testosterone replacement therapy on the standard cardiovascular risk factors, with a special emphasis on the role of testosterone as an immune modulator. With these beneficial physiologic effects of testosterone replacement therapy, it stood to reason that testosterone would be of value to men with coronary disease and congestive heart failure. We reviewed those studies and found that to be the case. Now, how did testosterone produce these clinical effects? testosterone works only by binding to the testosterone receptor on our coronary arteries and great vessels, or by binding to the androgen receptor, which is found in the heart, our great vessels, and in the cells of the immune system. Well, if testosterone deficiency causes cardiovascular disease, and if every cell in our body contains an androgen receptor, it stands to reason that testosterone replacement therapy might be of value outside of cardiovascular health. So in this section, we're going to review the non-cardiac benefits of testosterone replacement therapy. We'll start with a few more cardiovascular studies. This study, I didn't know exactly where to put it in, the coronary disease section or the heart failure section, so I snuck it in here. 48 sexually mature male rats were divided into 3 groups. 14 received a placebo, 17 received a single dose of long-acting testosterone, and a third underwent orchiectomy, androgen ablation therapy. The animals were then anesthetized, their hearts were removed, and put in a perfusion chamber. This is similar to the situation with open heart surgery on pump. The heart is isolated from the rest of your body and perfused to maintain viability. Now, what they did with these animals, they perfused their hearts normally for 20 minutes and then created ischemia. They cut off the supply of oxygenated blood and then they refused the heart for 30 minutes. This is akin to what would happen to your heart if you had a heart attack that was opened up with an urgent angioplasty, or what happens to your heart when you undergo open heart surgery on pump. And they're going to look at the effect of orchiectomy or testosterone on markers of recovery from this ischemia reperfusion injury. Now, end ischemic calcium level reflects biochemical scarring. It reflects mitochondrial failure. We've previously shown that testosterone has a beneficial effect on mitochondrial function in men with heart failure. In other words, VO2 max is better maintained. If we look at end ischemic calcium level within the cells of the heart, the animals subjected to orchiectomy, testosterone ablation therapy, had a greater degree of biochemical scarring. Conversely, the animals that were treated with testosterone before they underwent this experimental heart attack had less biochemical scarring, suggesting that mitochondrial function, the ability to generate energy from sugar and fat, was better maintained. Left ventricular filling pressure, when the heart has been damaged, it becomes stiff. The blood pressure within the heart rises, that makes you short of breath. And that was blunted with testosterone therapy. In other words, the heart was less stiff because it was better able to generate energy. Percent recovery of contractility, the ability of the heart to regain pump function, its ejection fraction, was not compromised by orchiectomy, but it was enhanced by testosterone. So in this experimental heart attack situation, testosterone replacement therapy lessened the damage due to ischemia. Now, at some point, a study will be done where men presenting with heart attack will be treated with testosterone. That study's not been done, but I would predict that outcome would be improved if we treated you with testosterone at the time of the heart attack. The effect of testosterone on non-healing lower extremity ulcerative lesions. 10 patients with long-standing lower extremity ulcerative lesions. 4 were due to arterial insufficiency, 6 were due to venous insufficiency. They just weren't healing up after approximately 2 years. So you measure the size of the ulcer, you treat all the patients with standard conservative measures, and then you treat them with testosterone. Various approaches to testosterone therapy were utilized, and then you monitor for lesion healing by adding testosterone to their prior best therapies. And all the ulcers healed in an average of 10 weeks. Here's a picture of a non-healing ulcer. You apply testosterone, it gradually fills in and heals. A Dr. Moeller in Holland made extensive use of testosterone in the treatment of men with cardiovascular disease in the 60s. And he's written 2 books, and I encourage you to read Dr. Moeller's books. His books contain pictures, they're not really pleasant pictures to look at, of individuals with advanced lower extremity vascular disease and active gangrene. Many of these patients were scheduled for amputation. With the administration of testosterone, lower extremity blood flow improved and the open skin lesions healed up. Quite impressive results. Testosterone and QT dispersion. We demonstrated in our study of testosterone replacement therapy in men with heart failure that autonomic function improves. If you recall, the baroreflex sensitivity improved. In men with cardiovascular disease, autonomic dysfunction reflects an imbalance between the sympathetic and the parasympathetic nervous systems, an overbalance where there's too much sympathetic fight or flight and not enough parasympathetic rest and repair. This can manifest itself in the EKG. The QT interval reflects the time it takes for the heart cells to repolarize. Now, we want all of our heart cells to fire to depolarize at the same time and then repolarize at the same rate. When the heart cells are damaged or the conduction system is dysfunctional or we have autonomic dysfunction, some of the heart cells will repolarize before the others. And the manifestation of this on the EKG is a prolonged QT interval. And this places you at risk for cardiac arrhythmia. So we like to see a short QT interval. If autonomic dysfunction can cause a long QT interval, let's see if testosterone can shorten or make the QT interval more uniform. 20 men with pump dysfunction and stable heart failure, you do a 12-week EKG, randomize them to receive over 12 weeks intramuscular testosterone, Sustanon, 100 milligrams every 2 weeks, or placebo, and then you repeat the EKG and analyze it. Testosterone level, of course, went up with active therapy, but not with placebo. The QRS duration, that is the time it takes for the heart cells to depolarize, we want to see a short QRS duration. It increased slightly with placebo, it decreased with testosterone. That is a positive sign. QT dispersion, reflecting an increased risk for arrhythmia, reflecting irregular repolarization, improved with testosterone. This would suggest that testosterone would be of value in cardiac arrhythmia in men. I'm not aware of any clinical studies of testosterone cardiac arrhythmia, but we would predict based upon the physiology that testosterone would be helpful. Another study of androgen ablation and what effect it has on ventricular repolarization. We've shown that testosterone therapy improves repolarization. Let's see what happens if we remove testosterone. What will that effect be on repolarization? Men undergoing androgen ablation therapy to address prostate cancer, you record their testosterone level and their QT interval. You carry out the androgen ablation therapy, then repeat the measurements. Testosterone levels plummeted. The physicians used a number of different agents to compromise testicular function, and you can see the testosterone levels fell nearly to nothing. The QT interval in response to androgen ablation therapy increased. So testosterone deficiency is associated with abnormal ventricular recovery, and testosterone therapy improves ventricular repolarization. Atrial fibrillation. Atrial fibrillation is a very common cardiac arrhythmia. The atria, the pacemaker fails, and the atria begin to beat like a sack of worms at 800 times a minute. With this, cardiac output falls, and you can experience congestive heart failure. Another worry is that when the atria are beating like a sack of worms, a blood clot can form, and it can be ejected from the heart and cause a stroke. And so if you have atrial fibrillation, we put you on lifelong anticoagulation. What are the causes of atrial fib? Well, it's age-related, and it's sort of a wear and tear mechanical problem. If you have heart failure, if you have high blood pressure, if you have valve disease, straining the heart, that increases your risk of atrial fibrillation. But metabolic factors also play a role because we know that magnesium, vitamin C, and fish oil are helpful in atrial fibrillation. If you're going to undergo open heart surgery and you're pre-treated with magnesium and vitamin C, you're less likely to develop atrial fibrillation as a consequence of open heart surgery. If you have atrial fibrillation and we're going to do an electrical cardioversion and we treat you with vitamin C, you're more likely not to revert into the abnormal rhythm. So metabolic factors play a role in atrial fibrillation. Now, the cells of the heart have androgen receptors. Testosterone is a physiologic molecule. Could testosterone deficiency be playing a role in atrial fib? Here we're going to take a study of 25 men with what's called lone atrial fib. They tended to be younger men, and they didn't have any structural heart disease, we really couldn't explain why they have atrial fibrillation. And we're going to look at testosterone estradiol levels in the men with lone atrial fib, compare that to 58 age-matched control subjects. There's no difference in the estradiol level, while the men with atrial fib, their testosterone levels were much lower. So we suspect that testosterone deficiency increases one's risk for different cardiac arrhythmias, in this study, atrial fibrillation. Now let's get into some of the non-cardiac effects of testosterone. A study of intramuscular testosterone therapy for 1 year in older men. 35 overtly healthy men, at least 50 years of age. They were free of significant medical problems, and they were really recruited as research subjects from a newspaper ad. They weren't under medical care. You do a baseline assessment, and then you randomize them to receive intramuscular testosterone every 2 weeks or placebo over 1 year, with periodic reassessment, and a double-blind protocol was followed. Testosterone levels did not rise significantly with placebo. They did rise with testosterone, although not dramatically. Estradiol levels rose minimally with placebo. They rose with testosterone, as you would expect. Whenever we give you testosterone, some will be converted into estradiol. Now let's look at grip strength of the hands. The scale shows change in strength. So below are the control subjects, on top are the testosterone subjects. Not a whole lot happened with placebo therapy, but grip strength increased with testosterone. Testosterone increases muscle strength. It increases muscle mass. Why? Because we have androgen receptors on our skeletal muscles. Body weight decreased with testosterone. Body mass index decreased. Percent body fat was unchanged. Leptin levels decreased. PSA increased from 1.5 to 2.0 with placebo therapy, a third. With testosterone therapy, the PSA increased from 1 to 1.9. That is a physiologic effect that we will discuss in the next section. There was no significant effect on cholesterol. Hemoglobin, the red cell count, did increase with testosterone. Now, testosterone is an anabolic hormone. It wants to build things. If you're anemic, testosterone is an excellent therapy. It will encourage the bone marrow, which contains the androgen receptor, to make more hemoglobin. We have to be watchful of this because many of our patients have lung disease or sleep apnea, and the oxygen levels in your lungs and in your blood will be low. Your body will compensate for the low oxygen levels by making more red cells, so your hemoglobin will be high. If we give you testosterone with its anabolic effects and your hemoglobin is high, it could rise to a level where your blood would become viscous. So what we do is we check your hemoglobin periodically. If it's high, we just say, give blood to the Red Cross, and that solves that problem. Another study of testosterone muscle strength, 8 middle-aged but overweight men. You do baseline measures of muscular function, strength such as weightlifting, endurance such as running. You treat them with topical testosterone gel, 250 milligrams every morning, and then you reevaluate them at 3 months. And what you find that muscle strength with respect to weightlifting, resistance exercise does increase, but endurance does not increase. Testosterone has effect on the muscle fibers to promote resistance strength, and glycogen is a storage form of sugar. In response to testosterone, your muscles store more glycogen, and it changes the biochemistry of the muscle fibers such that you have increased strength for resistance effort. Bone mineral density and cardiovascular disease. Now, what is bone mineral density and cardiovascular disease, have to do with one another? In this study, they took 209 patients, 26 men, the rest were women, and you carried a coronary angiogram, and if they have a 50% narrowing, they have coronary disease. You do a comprehensive risk factor assessment, the standard risk factors, and you do a DEXA scan for bone mineral density looking for osteoporosis. And then you construct the odds ratio, your risks for having obstructive coronary disease. Now, if you have high blood pressure compared to people who have normal blood pressure, you're 2.4 times as likely to have blocked coronary arteries. If you have a family medical history of heart disease, your risk increases. If you're diabetic, your risk rises a little bit over threefold. But the most important predictor was the presence of osteoporosis. If you have osteoporosis versus someone who does not have osteoporosis, you're 5 times as likely to have blocked coronary arteries. Now, when I think about osteoporosis, I think about calcium and vitamin D. I wonder what relationship vitamin D might have with cardiovascular disease and testosterone. First, let's look at the effect of testosterone on bone mineral density and body composition in men who are on long-term glucocorticoid therapy. That's prednisone, a steroid. We will treat autoimmune diseases such as rheumatoid arthritis with long-term prednisone. Now, prednisone will downregulate the activity of the T cells that are causing rheumatoid arthritis, but the problem is they downregulate the activity of the entire immune system, placing you at increased risk for an opportunistic infection. And there are many side effects of long-term corticosteroid or prednisone therapy, such as thinning of the skin, peptic ulcer disease, loss of muscle mass, we call that sarcopenia, obesity, osteoporosis, and steroids lower your levels of testosterone. Now, here we have 15 men with severe asthma requiring long-term prednisone or glucocorticoid therapy. You do the baseline assessment and then randomize them to receive monthly injections for 1 year of testosterone esters or placebo. You repeat the measurements at the end of 1 year, then you cross them over to the other therapy. What happens? Well, with the control therapy, nothing happens to testosterone, it remains low. Their normal range was 4 to 11, all these men were low. In response to testosterone replacement therapy, the testosterone level rose from 3.6 to 8.8, and after you stop therapy, it returned to normal. Again, if we treat you with testosterone, this will not permanently shut down testicular function. If we stop the testosterone, your level will return to the pre-treatment level. Sex hormone binding globulin was not changed, free testosterone levels rose, and estradiol levels did rise as well with testosterone replacement, as you would expect. Now, body composition. During placebo therapy, lean body mass decreased, and with testosterone it increased. The prednisone is catabolic. It tears down your muscles. The testosterone, when added to prednisone therapy, they stayed on the prednisone, you add testosterone, it increased lean muscle mass. Body fat was increased by steroid therapy. If you add testosterone to prednisone therapy, body fat decreases. Bone mineral density did not change with ongoing steroid therapy, and it rose by 5% with testosterone. Urine alkaline phosphatase, which is a marker of bone destruction, increased with placebo therapy, it decreased with testosterone. Testosterone is anabolic. There are androgen receptors in the bone, so testosterone, when given to individuals who are receiving chronic prednisone therapy, which is catabolic, can restore the abnormalities in body composition and in bone mineral density that are being torn down by the prednisone therapy. Low testosterone hip fracture. There's 200,000 hip fractures per year in the United States, and osteoporosis is the primary culprit. Risk begins 1 to 2 decades later in men versus women. It's age-related. After age 60, a man's fracture rate doubles with each passing decade. The cumulative risk, if we live to be 90, is 17%. There's significant morbidity, mortality, and cost. Now, young hypogonadal men develop osteoporosis that is reversible with testosterone. So the question here is, does testosterone deficiency increase a man's risk of hip fracture? Minimally traumatic hip fracture is a hip fracture related to non-severe trauma. Now, if I'm on the top of a stepladder and I fall on my hip, it might break. That would be a normal break. But if I just slip in the bathroom and hit the ground not that hard and I fracture my hip, that is a minimally traumatic hip fracture, and that pretty much indicates that I have osteoporosis. So we're going to look at a 120-bed VA nursing home unit, and we're going to evaluate 84 male vets who are over 65 years of age. And we're going to look at their testosterone levels, and the normal range by their scale was 9 to 46, so below 9 would be hypogonadism. And we're going to record the past or present occurrence of minimally traumatic hip fracture, and we'll also look at risk factors for hip fracture, including alcohol abuse, smoking, or metabolic abnormalities. 27% of the vets in the nursing home were hypogonadal. 29% had sustained a hip fracture. Now, the men with hip fracture were less likely to be overusers of alcohol, less likely to smoke, less likely to have a metabolic problem, but their testosterone levels were lower. Their mean level was 9.7 versus 12.7 of the men who had not experienced a hip fracture, and 59% were hypogonadal. So the standard risk factors were not predictive of minimally traumatic hip fracture in middle-aged and elderly men, but the presence of hypogonadism was a strong predictor. They looked at odds ratio, and if you were a smoker, you were 20% more likely to have a hip fracture versus a non-smoker, but if you had a low testosterone level, you were 6.5 times as likely. 48% of the hypogonadal elderly men had sustained a hip fracture. So low testosterone leads to osteoporosis and poor muscle strength, so maybe you're more likely to fall, dramatically increasing your risk of a hip fracture. Now let's study the effect of testosterone on bone mineral density. We're going to take 48 normal men, normal, fairly healthy men who lived in Australia, measure bone mineral density, dietary calcium intake, testosterone levels, look for relationships and correlations. You can see that as dietary calcium intake increases, bone mineral density increases in lockstep. That makes sense. We know that we need calcium for bones. The more calcium you take in, the stronger should be your bones. They also found the higher your testosterone level in these healthy young men, the stronger were their bones. Another study, 13 hypogonadal men with low testosterone, 7 had 2 or more vertebral crush fractures, a manifestation of osteoporosis. 6 were hypogonadal that had not had a vertebral fracture, and there's no prior therapy for osteoporosis, and there was no prior testosterone replacement therapy. Do the baseline measurements and treat 9 of the hypogonadal men with testosterone esters, Sustanon, 250 milligrams every 2 weeks, and then you reevaluate them. Testosterone levels rose with therapy, and of great interest, 125 vitamin D levels increased. Now, vitamin D is manufactured from cholesterol in our skin in response to sunlight. That's interesting. Testosterone's made from cholesterol. Vitamin D is made from cholesterol. In our skin, we generate 25 hydroxy vitamin D. 25 hydroxy vitamin D enters our cells, particularly cells of the kidney, but many cells in the body, where an enzyme adds on another hydroxy group. So we generate the 25 hydroxy D in the skin, and then we have to convert it to its active form, 125 hydroxy vitamin D. And it's the 125 that promotes calcium absorption from the gut and calcium deposition in bone. And if you look at the ratio between 125 vitamin D in the blood, you can see the higher your 125 D levels, the greater is your calcium absorption. So the thinking here is that testosterone increases the enzymes that convert 25D into the active form 125. This is one of the mechanisms by which testosterone increases bone mineral density and prevents or treats osteoporosis because it activates vitamin D. Calcium absorption was greater with testosterone therapy. They did bone biopsies and they measured several parameters. One is called seam width. Seam width improved with testosterone, showing that yes, you're activating D, yes, you're now absorbing more calcium, and indeed, you're putting the calcium into the bone with testosterone replacement therapy. Study of 50 hypogonadal men, 65 years of age or older, testosterone's below 350, PSA was below 4 with the normal digital rectal exam. You measure hormone levels and bone mineral density. You randomize them to receive over 3 years testosterone ester therapy, 200 milligrams every 2 weeks, plus finasteride, 5 milligrams every day. Finasteride is the generic name for Proscar. Proscar blocks the enzyme 5-alpha reductase. 5-alpha reductase in the prostate and elsewhere in the body blocks the conversion of testosterone into dihydrotestosterone. It's really not testosterone, but dihydrotestosterone that mediates prostate growth. So the point of this study was, if we were concerned about the effects of testosterone on the prostate for fear that we would increase the rate of enlargement of a hypertrophy prostate, or perhaps increase the growth rate of a pre-existent prostatic malignancy, let's give testosterone and obtain its benefits while blocking its conversion to DHT. Can we produce clinical benefits without causing as much growth effects on the prostate? So one group got testosterone and Proscar, another group received testosterone, a third group received placebo, sesame oil vehicle intramuscularly. And then you follow them over 3 years. Now what you find here, total testosterone did not change with placebo therapy. It rose with testosterone alone and testosterone plus Proscar. It rose a little bit more in the testosterone plus Proscar group because if you block the conversion of testosterone to DHT, there'll be a little bit more testosterone floating around. The same relationship with bioavailable testosterone. Serum DHT did not change with placebo therapy. It did rise with testosterone. If we give you testosterone, some will be converted into DHT. And of course, the level fell with testosterone and Proscar, just as it would fall if you received Proscar without testosterone. Serum estradiol did not change with placebo therapy. It rose as expected with testosterone, and it rose a little bit more in the group that received testosterone and Proscar, because if you block metabolism of testosterone to DHT, you got a little bit more floating around, so estradiol conversion would naturally increase. The effect of bone mineral density at the lumbar spine and at the hip improved significantly with testosterone and testosterone with Proscar. Urine deoxypyrolinine is a marker of bone breakdown. You want to see a low level bone breakdown. The urine level fell with both testosterone groups. Now the point of this study was, we think testosterone's a good idea. It has a lot of benefits. We're concerned about its effect on the prostate. If we give you testosterone and block conversion to DHT with Proscar, will we still get the clinical benefits of testosterone? And with respect to bone mineral density, the answer is yes. This type of analysis has not been done with respect to testosterone therapy in cardiovascular disease and other conditions, but likely we could give you Proscar, block the conversion of testosterone to DHT, and still you would receive the same cardiovascular benefits. That study just hasn't been done yet. PSA rose with placebo therapy. PSA tends to rise over time in men. With placebo therapy, it rose from 1.4 to 1.7. With testosterone only, it rose a little bit more from 1.0 to 1.4. With testosterone and Proscar, which blocks the conversion of testosterone to DHT, and it's really DHT that stimulates the prostate to grow and release PSA, there was really no significant change in PSA. Prostate volume increased a little bit with placebo therapy. As we age, BPH tends to increase. It rose a little bit more with testosterone. It rose less if you block the conversion of testosterone to DHT, as you would predict. Another study of testosterone and bone mineral density. 167 hypogonadal men with at least one prior DEXA scan to assess bone mineral density. Their average age was 55, fairly young men, mixed causes of hypogonadism. And you look at their prior treatment status. 14 had never received testosterone replacement therapy. 40% were partially treated. They had received less than a full year of physiologic testosterone replacement therapy, or their compliance with therapy was low and their levels had not been maintained in the therapeutic range. 46% were well treated. They were receiving pellet therapy, 800 milligrams every 6 months, or they were coming in for testosterone injections every 2 weeks. And you're going to look at bone mineral density by the DEXA scan. We can look at the raw bone mineral density. The T-score compares your bone mineral density against young adults. The Z-score compares your bone mineral density against individuals of your age and gender. And you're going to treat all these men with pellet testosterone replacement therapy, 800 milligrams every 6 months, which dependably will give you a physiologic on-treatment level. You're going to repeat their bone mineral density in 3 years and see what effect this has. Now, Bone mineral density over the lumbar spine in those that had never been treated for hypogonadism was low at 1.115. Those that had had kind of spotty, sporadic treatment, they remained osteoporotic. Those that had received therapeutic testosterone replacement therapy with physiologic on-treatment values, their bone mineral density was significantly better. The T-score of those that were hypogonadal and untreated or partially treated was lower than those with effective therapy, and the same with the Z-score, which relates your bone mineral density to individuals of your gender and age. Now, we're going to treat them all with pellet therapy, give them physiologic on-treatment values. What is the change in bone mineral density? Now, those that were hypogonadal and never treated got the biggest kick. Their bone mineral density increased the most. Those who had been partially treated or previously effectively treated, they continued to improve. Percent gain per year was greatest in those that were untreated beforehand. The gain was a little bit less in those with partial treatment. Those with full treatment continued to improve with physiologic pellet testosterone replacement therapy. Statins. Statins are the most popular lipid-lowering drug in North America. Statin therapy lowers cholesterol, and because high levels of oxidized cholesterol in the artery wall initiate the immune response that characterizes atherosclerosis, the greater your level of cholesterol, the greater is the likelihood it will be oxidized and you will develop atherosclerosis. So statins are used to lower cholesterol. But it's an interesting thing, the clinical benefits associated with statin therapy are head and shoulders superior to those of other drugs that lower cholesterol via other methodologies. So we need to understand, how do statins actually work? Now, they block the generation of isoprenoid molecules. There's a long assembly line through which we generate cholesterol, and statins block a step, and they lower the levels of isoprenoids. And isoprenoids are signaling molecules that activate the immune and inflammatory response. Specifically, if you take a statin, the way it's really helping you is blocking farnesylation and geranylation of RAC, RO, LAS, and laminin. And I just love saying that because it was very difficult to learn how to say it blocks geranylation. Now, why would this be helpful? We know that people with atherosclerosis all suffer from immune system upregulation and intense inflammation. Statins downregulate the immune system and inflammatory pathways. So, if you are older and you have advanced cardiovascular disease and you're on fire, you just had an episode of unstable angina or TIA, we know that your immune system's upregulated. Statin therapy is a great idea. It's a no-brainer. There's a great deal of benefit for you. Conversely, if you're 30 years old and you're in pristine health and your cholesterol's a little high, going on statin therapy is not a good idea because you're decades away from experiencing atherosclerosis. Your immune system is not upregulated. You have very little to gain from statin therapy and perhaps much to lose. Statins not only block the generation of cholesterol, they block the generation of all the molecules our body makes from cholesterol. Coenzyme Q10 is generated from cholesterol. Coenzyme Q is needed for energy generation. Without coenzyme Q, we cannot make ATP energy from sugar and fat. Coenzyme Q deficiency is present in individuals with all forms of cardiovascular disease, and all forms of cardiovascular disease have been shown to respond quite dramatically in some disease situations to coenzyme Q. So statins waste a key biological molecule. What effects will this have? We have 14 asymptomatic subjects without known heart disease. They have high cholesterol and they are set to begin statin therapy. So at baseline, you record their coenzyme Q level, you do a cardiac echo and look at measurements of diastolic function. Is the heart stiff or does it relax well? And we need to understand that for the heart to relax, it takes more energy than for the heart to contract. So you need coenzyme Q. If you're coenzyme Q deficient, your heart becomes stiff. So they do the baseline studies, treat them all with Lipitor, atorvastatin, a standard statin. You repeat the echo at 3 to 6 months and look for a change. If there was evidence that the heart was becoming stiff, you keep them on Lipitor and add coenzyme Q to see if you could rectify diastolic dysfunction on the basis of statin-induced coenzyme Q deficiency. And what you find is that 71% of these healthy people in response to statin therapy demonstrate a deterioration in diastolic function. Those that did not develop a stiff heart had above average coenzyme Q levels. If you recognize this problem, you've depleted your patient of coenzyme Q with a statin. Well, okay, give them a statin, they may need it, give them coenzyme Q, and the problem reverses itself. So diastolic dysfunction due to statin therapy can be ameliorated or neutralized by coenzyme Q. The muscle aching, the myalgias that many of our patients experience on a statin is due in part to coenzyme Q deficiency. Many of you will experience relief if we add coenzyme Q. Another paper that just came out, if you're having muscle aching on a statin and it's not responding to coenzyme Q, vitamin D may help. Now, why would that occur? Well, remember, we make coenzyme Q from cholesterol, and that's compromised by a statin. We make vitamin D from cholesterol, and cholesterol synthesis is compromised by a statin. What else is made from cholesterol that might be compromised with statin therapy? How about testosterone? Here we're going to take 8 middle-aged men with hyperlipidemia, do the baseline studies, you look at their lipids, you look at hormone levels, and then you do an HCG challenge test. HCG is human chorionic gonadotropin. It's made by the placenta, and its job is to mobilize energy from mother to child. In our weight loss program, we will treat men and women with very small doses of HCG. The placenta makes 1 million units a day. We use 125 units. HCG looks a lot like LH, luteinizing hormone. That's the hormone made by the pituitary to stimulate the testicles to make testosterone. So you can do an HCG challenge test where you give a huge dose, 5,000 units, that will stimulate the testicles to make testosterone if the testicles are functioning normally. So they do that challenge test. Then they treat them all with simvastatin, 80 milligrams a day. You repeat the lab studies over the course of a year. And you can see in response to statin therapy, the cholesterol level fell, as you would expect, from 255 to 191. And the testosterone level fell, as you would expect. It fell by about 20%, from 513 to 424. Now, the researchers didn't think that was functionally significant, but I think it's huge. Remember, testosterone has a favorable effect on nearly all cardiovascular risk factors. Testosterone therapy is effective in heart failure and coronary disease. We don't really want to lower our testosterone levels by 20%. Free testosterone level fell from 22 to 17. Estradiol levels rose. So the estradiol to testosterone level rises with statin therapy. The response of the HCG challenge test, the top curve, this is testosterone levels over time following the HCG stimulation, was normal at baseline. Over time with statin therapy, the ability of the testicles to respond to HCG and generate testosterone was compromised. So testicular function is compromised by statin therapy. Gentlemen, what side effect is quite frequent with statin therapy, a side effect that you find quite troublesome? Well, one is depression. Many of our patients say, gee, doc, I'm down, I'm blue, I don't feel good anymore with statin therapy. Now, I won't show it to you here, but studies have been done showing that men with low testosterone are at greater risk for depression than men with normal testosterone levels. Here, let's look at the effect of testosterone therapy in men with depression not responding to SSRI therapy, the selective serotonin reuptake inhibitors. 5 men with depression not responding to drug therapy, and they'd been on Paxil or Prozac at standard doses, and their testosterone levels were low or low normal. You do a baseline evaluation. The HAM-D is a questionnaire of depressive symptoms. You treat them all with fairly high doses of testosterone, reevaluate at 8 and 14 weeks. And then, without telling them, you substitute sesame seed oil for testosterone and see what effect that has. Now, The HAM-D depression score fell dramatically with testosterone replacement therapy, and then when they were taken off testosterone without them knowing it, they became depressed again. This is the raw data for the 5 patients. Now, this one man wouldn't hang around for the placebo study. He goes, wait a minute, I'm going to find another doctor to give me testosterone because I feel so much better. So testosterone deficiency is associated with an increased risk of depression. Testosterone replacement therapy will improve depression that persists despite medical therapy. Testosterone and verbal and spatial memory. We have androgen receptors in our brain. Well, does testosterone deficiency compromise cognitive function? Is this one of the reasons cognitive function declines in men with age? Will testosterone replacement therapy improve intellectual function? 25 healthy men, age 50 through 80, you do a baseline evaluation of cognitive function, randomize them to receive once a week over 6 weeks, intramuscular testosterone, 100 milligrams a week or placebo, and then you reevaluate cognitive function periodically. And a double-blind protocol was followed. Testosterone levels and estradiol levels rose in response to testosterone replacement, as you would expect. These levels did not change with placebo. Spatial ability, block design completion. Here we give you a box containing pieces of paper cut in different shapes. You have to put the shapes together to form a square. And over time, your ability to do this improves, and the time it takes to put the pieces together to create a block will shorten, but it shortened a lot more with testosterone replacement therapy. So this cognitive function was improved. Verbal memory recall, we tell you a story and then ask you questions about the story. Kind of like we all did in 3rd grade, you do a better job remembering details of the story with testosterone. Spatial memory, the route test. What they do, they kind of create a maze in the office building, and they teach you how to walk through the office, go from point A to point B with some twists and turns. And then they measure how effective you are at remembering the route. And you can see with testosterone therapy, the men did a much better job of finding their way through this maze. And I think this is a critically important piece of information. You know, when you're out for a drive and you're going to a new location you've never been before, and you're with your wife or a female significant other, and you can't find your way, and your wife begins to nag you about stopping and asking for directions. Well, that's really not the case. You see, in individuals with 2X chromosomes, women, it is genetically mandated that they provide directions. I mean, women make better mothers than we do, and it's part of their genetic makeup to provide men with directions to go to new locations. So if you're getting lost and your wife's giving you a hard time, you know, don't let her say that you don't know how to get there. Say, honey, no, you made the mistake. It was your fault that we did not have good directions, because with our testosterone levels, we're really good at finding our way. So this is very, very important. Now, summary of the non-cardiovascular clinical benefits. Diabetes control improves, muscle mass and strength increases, abdominal fat, percent body fat decreases, bone mineral density increases, useful in osteoporosis. It'll reverse the osteoporosis due to chronic steroid therapy. Mood and energy level increases. It's useful in depression. Increased libido, level of interest in life in general. Immune system modulation. Wound healing is accelerated. Possible benefit in arrhythmia. And statin side effects are partially due to testosterone wasting, and vitamin D deficiency and coenzyme Q deficiency may also play a role in statin-related side effects. So we've talked about the cardiovascular and the non-cardiovascular benefits of statin therapy. In the next section, let's look at the effect of testosterone on genitourinary, prostate, and bladder health in men. Let's study the effects of testosterone on prostate and bladder health. Now here we really need to be sure that we're going to keep our brains out of the box. Doctors of my age or physicians older than me, we were taught incorrectly that testosterone aggravates genitourinary symptoms in men and that testosterone causes prostate cancer. Yes, testosterone is the one and only cause of prostate cancer. And this is totally incorrect. This is based upon the Higgins hypothesis. Dr. Higgins was the first researcher and clinician to effectively treat men with metastatic prostate cancer by utilizing androgen ablation therapy, either orchiectomy or administering medications that compromise testosterone synthesis in the testes. And androgen ablation therapy was effective. It decreases the growth rate, the rate of spread of metastatic prostate cancer, and decreases the cancer-related death rate. But as we discussed in one of our earlier sections, it didn't have a beneficial effect on overall death rate because androgen ablation therapy increases cardiovascular death rate. But it is a fact that if you have metastatic prostate cancer, depriving the cancer cells of testosterone will slow down their growth rate, and that would be of value. Because testosterone ablation therapy decreases the growth rate of metastatic prostate cancer, an incorrect extrapolation was made that testosterone causes prostate cancer, and that if we give you testosterone, you're going to get prostate cancer. That is brain in the box, wrong thinking. Another piece of misinformation that I've been giving you, I've been saying that testosterone restores libido and interest in intimacy, but it does not improve erectile function, and that is incorrect. We are learning now from some recent papers that testosterone, yes, it improves libido, but that testosterone is necessary for erectile function. So my position was wrong. In response to new research, I'm changing my position. Isn't that interesting? Because I don't want to have brain in the box, wrong thinking. Now, based upon the articles that I have read, my position on testosterone in male genitourinary health is as follows. We know that testosterone receptors, or androgen receptors, are present in all male genitourinary organs. Thus, testosterone is necessary for prostatic development and function. If you undergo orchiectomy young in life, you will not develop normal prostate function. You'll never get prostate cancer. Testosterone is also necessary for normal bladder function, and it's necessary for normal erectile function. Dihydrotestosterone, derived from testosterone by the enzyme 5-alpha reductase, is the major stimulator of prostatic growth. Dihydrotestosterone derived from testosterone in the circulation, or the lion's share of it is derived from testosterone within the prostate. Now, low testosterone, or otherwise stated low prostate tissue DHT, is associated with a relatively smaller prostate volume, a relatively lower PSA. Prostate cells, normal cells, and malignant cells require some testosterone to grow at an appropriate rate. So in the absence of testosterone, the absence of dihydrotestosterone, you're going to have a smaller prostate and a lower PSA, all other things being equal. 5-alpha reductase inhibitors, such as Proscar, blunt DHT formation and are associated with smaller prostate volumes, lower PSA values, and a decreased risk of prostate cancer. This hasn't been all worked out yet, but the 5-alpha reductase inhibitors probably don't actually decrease your lifetime risk of cancer, but because they deprive the cancer cells DHT, it slows down the division rate of the cancer cells, delaying the point in time when the cancer becomes obvious clinically. Before we experience symptoms of prostate cancer, before the PSA rises markedly, before we would develop a nodule on our prostate, the cancer process has been present for 7 to 10 years. So if we blunt the generation of DHT in the prostate, we will deprive the cancer cells of its nourishment, and we will delay the expression of the cancer by slowing down its growth rate. And the same thing for benign prostate tissue. So you have prostate enlargement, and you take Proscar, your DHT levels in the blood and the prostate will fall, and your prostate will shrink, and your PSA will fall. The testosterone level is not predictive of prostate malignancy risk. The higher your testosterone that does not translate into an increased risk of malignancy. As we'll see, it's just the opposite. Physiologic testosterone replacement therapy, achieving physiologic levels in men who were hypogonadal, will increase prostate volume and PSA. If your testosterone levels are low, your prostate would be smaller and your PSA level would be lower than it otherwise would be if you had a physiologic level of testosterone. Now, testosterone is not the only factor that determines prostate size and risk of malignancy. Many other factors play a role, but all of the things being considered, if your testosterone level is low, your prostate will be smaller and your PSA will be lower if you have normal prostate tissue or if you have malignant cells in your prostate. Testosterone replacement therapy, physiologic, improves voiding symptoms. It's of value in erectile dysfunction. It will increase the growth rate and the PSA release of pre-existent malignant cells, but it does not precipitate malignant conversion. It does not cause cancer. Now, if I'm treating you with testosterone and your PSA is low and your rectal exam is normal and we're watching you over time and all of a sudden your PSA rises and I say you need to go to the urologist and get a biopsy, if we find cancer, you really can't say that I caused your cancer. The testosterone caused your cancer. If I treat you with physiologic testosterone and your PSA rises and we find cancer, to say that I caused the cancer would be to say that if you have risk factors for cardiovascular disease and I do a stress test and find an abnormality, that I caused your coronary disease. If you're a smoker and I do a screening x-ray and I find a nodule and we diagnose your lung cancer 7 years before you would have found out about it when you're coughing up blood, that doesn't mean that I caused your lung cancer. If your wife or your spouse, following a careful evaluation with their OBGYN physician, goes on hormone replacement therapy and 2 years later the mammogram becomes abnormal, that doctor didn't cause the cancer. The estrogen replacement therapy didn't cause the cancer because we know that lung cancer, prostate cancer, breast cancer will exist for 7 to 10 years in a dormant, slowly growing state before it manifests itself clinically. So if a woman receives hormone replacement therapy and we suddenly find an abnormality in the mammogram, or if a man with a normal rectal exam and a normal PSA suddenly experiences a rise in PSA and we find the cancer, we didn't cause the cancer, we just increased the growth rate of the cells, allowing us to find it early when it's potentially curative, as opposed to doing nothing and it would show up on its own years later, perhaps in a metastatic or more difficult to treat condition. So that's a very important point. Now, supraphysiologic testosterone administration, such as you're giving high doses to young men to see what effect it has on contraception, does not increase prostate volume or PSA. So if you have a normal level of testosterone pre-treatment and we give you more testosterone, that won't do anything to your prostate or your PSA. The prostate needs just enough testosterone to function normally. If we give you more, the prostate won't take up more. There's limits into the amount of testosterone that the prostate will take. Supraphysiologic testosterone administration would not increase the growth rate of prostate cancer more than testosterone replacement therapy might. It needs a certain amount, and if you give it, it will grow at the rate that it would have grown had your testosterone level been normal. Androgen ablation therapy, drugs to compromise testicular function, or orchiectomy castration will decrease the growth rate of metastatic prostate cancer and of course remove all the physiologic benefits of endogenous testosterone. The point here is that normal and malignant cells need and respond to physiologic levels of testosterone. Supernormal testosterone does not add to or aggravate this relationship. Now, here's an interesting study of testosterone, SLO, and LUTs. 25 men with SLO, symptomatic late onset hypogonadism, age 38 through 73, their testosterone levels were low, the mean level was 214. You do a baseline evaluation for LUTs. lower urinary tract symptoms. You look at their physiologic status, prostate volume, PSA, and urodynamics, the rate at which your bladder can expel urine. You'll look at symptomatic status with several scales. The IPSS is the International Prostate Symptom Score, symptoms of prostatism. The AMS is the Aging Male Symptom Scale, symptoms of testosterone deficiency. And the IEF is a questionnaire regarding your level of erectile function. You're going to do the baseline evaluation, treat them all with a testosterone gel called Testogel, repeat the measurements at 1 year. Testosterone levels will rise with supplementation. The prostate will increase in size, and the PSA rose from 1.26 to 1.44. And that is physiologic. Their prostates were smaller than they otherwise would be. Their PSAs were lower than they otherwise would be because of the low levels of testosterone. You take them into the physiologic range, and there's a slight increase in the size of the prostate and in the PSA value. Bladder compliance. The elasticity of the bladder. We want a compliant, elastic bladder. It feels better. Increased with testosterone. Maximal bladder capacity increases. You can hold more urine. The force exerted by the bladder muscles to empty the bladder when you're sort of straining to push, you don't want to have to generate a lot of force, and that was decreased because the bladder's functioning normally. You don't have to strain as much. Post-void residual. If you have an enlarged prostate, you cannot empty your bladder. You'll retain urine in your bladder. That was not increased with testosterone. Urinary flow rate was unchanged, but symptoms of prostatism were improved. So the prostate increased a little bit in size, not markedly, but bladder function improves. You empty your bladder better, you have fewer genitourinary symptoms. The testosterone level rose. The symptom score of andropause decreased, the prostate symptoms decreased, and erectile function improved with testosterone replacement therapy in these men. Now let's talk a little bit about erectile dysfunction. I used to say that erectile dysfunction was due only to endothelial dysfunction, the inability to convert arginine into the vasodilator nitric oxide. Well, erectile dysfunction is due to endothelial dysfunction and or testosterone deficiency. Let's discuss the physiology of erectile function. Now, contrary to what women say, when it comes to sex, well, we are thinking with our big heads. We have to have an interest in sex, a cerebral arousal. That sends off a signal that traverses the spinal cord to the pelvic nerves that release acetylcholine. Acetylcholine is a neurotransmitter that stimulates the enzyme nitric oxide synthase to convert arginine into nitric oxide. Nitric oxide actually increases the levels of cyclic GMP that causes vasodilatation. The penile artery arterioles begin to vasodilate. There is a sphincter that prevents the flow of arterial blood into the penis at the resting state. In response to nitric oxide and cyclic GMP, that sphincter is released, so the arterioles of the penis are exposed to the systemic blood flow at systemic pressure, so they will engorge, and that fills up a space called the corpora cavernosa. Now, so arterial blood flows into the penis, and of course it can flow out through the veins, but the veins are very thin-walled and they collapse. So basically, arterial blood is trapped within the penis. That causes an erection. Now, while we're making nitric oxide and while we're making cyclic GMP, we have to break down the cyclic GMP, otherwise there would be a circumstance that nobody would want to have. So the enzyme that breaks down cyclic GMP is phosphodiesterase, and this is an ongoing process. But as long as we're thinking sex, we're making cyclic GMP at a greater rate than we're breaking it down, and an erection is maintained. Now, if suddenly there's a knock on the door, "Mommy, Daddy, I'm scared, I can't sleep," well, you quit thinking about sex, you start thinking about your kids, you stop making nitric oxide cyclic GMP, phosphodiesterase will break down the cyclic GMP, blood flow to the penis decreases, and the erection will resolve. Viagra is quite effective. How does Viagra work? It blocks the phosphodiesterase enzyme. Men with erectile dysfunction, you're still making some nitric oxide and cyclic GMP, you're just not making much. So we can't help you make more due to metabolic and vascular problems, but if we can block the breakdown, then you can maintain adequate levels of cyclic GMP to have normal erectile function. Now, within the arteries, particularly the coronary arteries, we are converting arginine to nitric oxide with nitric oxide synthase, and that is important in maintaining arterial tone. The reason if you have coronary disease and you're taking long-acting nitrates, you can't take Viagra. Long-acting nitrates, nitroglycerin, isosorbide mononitrate, isosorbide dinitrate, give you nitric oxide in a chemical or a drug form. So there's an awful lot of that floating around in your body. We have phosphodiesterase in the coronary arteries to prevent us from having an exaggerated or sustained nitric oxide effect in response to drug therapy. If you take these long-acting nitrates and take Viagra, not only will you block phosphodiesterase in the genitourinary system, you'll block it throughout the body and your blood pressure will fall to the floor. So Viagra is not unsafe. It does not have undesirable side effects, except you can't take Viagra and nitroglycerin. That would be, it's absolutely contraindicated. Now, so erectile function is a vascular matter. However, it's been shown recently that you need testosterone to have normal function of nitric oxide synthase and phosphodiesterase in the male genitourinary system. So no testosterone, these enzymes don't work well, and you will experience erectile dysfunction. Well, will testosterone be a value? You would predict that it would be. Let's look at the effects of testosterone in 32 hypogonadal men with erectile dysfunction not responding to Viagra at the highest dose of 100 milligrams a day. So they were Viagra failures. You'd look at baseline hormone levels and the IIEF scale of erectile function. You treat them with oral testosterone undecanoate, 80 milligrams, 2 to 3 times a day over 2 months. And if testosterone therapy alone was not successful, you would add Viagra to testosterone replacement therapy. Viagra alone didn't work, but let's see if Viagra plus testosterone worked. The testosterone levels rose from 220 to 415 with testosterone. They were a little bit higher with Viagra and testosterone. We think that's spurious. We don't think that Viagra actually increases testosterone. Now, the IIEF symptom scale, these men weren't doing very well. They had a low score at baseline. Viagra was not very helpful, rose only from 12 to 12.6, but if you gave them testosterone, it rose to 14.8. In the men that did not have a complete response to testosterone, they received testosterone and Viagra, and the symptom score improved further. Now, none of these men were doing well with Viagra. 34% were able to resume sexual activity in a satisfactory fashion with testosterone alone. 38% experienced normal sexual health with the combination of Viagra and testosterone. Only 28% had persistent ED. So men with ED, if your testosterone levels are low, the first line therapy is testosterone. It's good for your ED, it's good for your brain, it's good for your bones, it's good for your heart. It's a very good idea. If testosterone alone is not effective and we add Viagra, another 38% of you are going to improve. Only 28% of hypogonadal men who were not responding to Viagra were troubled by persistent ED. Now, the concern we have with testosterone replacement therapy, and really the only important concern, is this worry about the risk of prostate cancer. So let's discuss this in detail. We're going to look at the Scandinavian case control study. We'll look at testosterone levels drawn and banked on ice 4 to 17 years earlier from 708 men who subsequently were diagnosed with prostate cancer. And for a comparison group, we'll look at over just 2,000 men who did not develop prostate cancer. They were matched for age, residence, time of blood draw. There were 4 controls for every cancer case. The mean age at blood draw was 47 years, and these were banked frozen blood samples drawn from 2,000 Scandinavian men. One of the benefits of a national or socialized medical system is that everyone's on the same page, labs are drawn and measured in standardized labs, so the Scandinavian countries have some of our best epidemiology, because in the United States we will look at select groups of people. In Scandinavia we can look at all Scandinavians. We're going to compare baseline testosterone levels with your future risk of prostate malignancy. The men that eventually went on to develop prostate cancer their testosterone levels were lower, 23.5, compared to men who did not experience prostate cancer down the line at 24.6. Their free testosterone levels were lower. Body mass index was a little bit greater. So a high testosterone level is not associated with an increased risk of prostate cancer. It's actually the opposite. Men with lower levels tend to have an increased risk of malignancy. The relative risk of experiencing or developing prostate cancer in men versus the lowest quintile of testosterone, the lower 20%, you can see that men in the 4th and 5th quintile of total testosterone or the 5th quintile of free testosterone actually had a lower risk, as did men in the 1st quintile. What's the explanation here? Well, if your testosterone levels are really low, your prostate tissue is growing slowly. If it's malignant, it's going to grow slowly. So these men may have been developing a prostate cancer, but during the duration of the study, it hadn't had a chance to grow enough to be noticed. But the point of this is that men with the highest levels actually have the lower risk. Why? Perhaps men with higher testosterone levels are healthier. They eat better, they're more vigorous, they have better cardiovascular health. But the point is that if your testosterone level is high normal or physiologic, that does not increase your risk of subsequent prostate cancer. Actually, it probably decreases it. Prostate cancer risk with a PSA below 4. PSA is prostate-specific antigen. It is a protein made in the prostate tissue. It can be made by normal cells or malignant cells. Your PSA level is an indirect measurement of prostate volume. From a single PSA level, we don't know whether the PSA is coming from normal cells or malignant cells. We have a cutoff of a PSA of 4. Below 4 is normal, above 4 is abnormal, and that is an artificial man-made construct. If we say that if the normal upper limit of normal of cholesterol is 200, that doesn't mean that if you're 201 you're going to have a heart attack, and 199 you're never going to have a heart attack. Those are man-made cutoffs. Let's look at 345 consecutive men presenting with symptoms of hypogonadism. Their testosterone levels were low. Their PSA was normal, below 4, mean age 59. They all undergo a rectal evaluation and a prostate biopsy. And we're going to look at cancer detection rate in relation to the PSA level, the testosterone level, and the findings on the digital rectal examination. Now, 15% of the men with a PSA below 4, normal, quote unquote, did have prostate cancer. What factors predicted a risk of prostate cancer in men with PSAs below 4? Well, they were a little bit older, their PSAs were a little bit higher, their testosterone levels and free testosterone levels were lower, their prostates were a little bit larger, 38 versus 34 cc's, their rectal exam was more likely to be abnormal, a nodule or swelling, 38% versus 28%, and PIN, which is prostatic intraepithelial neoplasia. It is not a cancerous cell, but it shows disorganized cellular activity. It is akin to an abnormal pap smear in a woman. It doesn't mean you have cancer, but it means that we're concerned. And PIN was found 48% versus 18%. If we looked at the prevalence of a positive biopsy as a function of age, men in the 7th decile and above had a 28% risk versus 13% in younger men. The most important predictor of cancer, of any sort of cancer, I think, is age. The prevalence of prostate cancer versus PSA. Remember, we say 4.0 is normal. Well, if your level was below 1, your risk is 6%. 1.1 to 2, it's 17%. 2.1 to 3, it's 26%. 3.1 to 4, it's 36%. It's not an absolute cutoff at 4. It's all on a continuum. Let's look at the prevalence of prostate cancer versus testosterone status. The subjects with lower testosterone levels and a PSA below 4 were more likely to have cancer compared to the subjects with a higher testosterone level. And this makes perfect sense. Let's say you have 1,000 men with a PSA of 2. And some of the men have low testosterone, others have normal. They all have a PSA of 2. And remember that testosterone is necessary for normal and malignant cells to grow and make PSA. If you biopsy these men, you would find a relatively increased incidence of cancer in the men with a PSA of 2 and a low testosterone as opposed to the men with a PSA of 2 and a high testosterone. Normal and malignant cells need some testosterone to function and grow normally. So if your testosterone levels are low, that might mask a prostate cancer by, all other things being equal, artificially lowering your PSA. So we need to keep that in mind. Now, biochemical stress tests. We've said that if your testosterone levels are low, your prostate will be smaller, your PSA will be lower, and if you have a malignancy, the PSA will be relatively lower. What's going to happen if we give you a large dose of testosterone? What effect will that have? A differential effect on the PSA if you have normal prostate versus malignant prostate cells? Here we're going to take 40 consecutive men with a PSA between 2.5 and 4, a normal rectal exam, mean age 58, their testosterone levels were above 250, no other genital urinary problems. Do baseline lab studies, all receive a single 400 milligram dose of intramuscular testosterone. That's a pretty high dose. Normally we'd use 100 to 200 milligrams. That is a super physiologic dose, but they did that for a purpose. You're going to repeat the lab studies over 28 days, and then at 28 days, all 40 men undergo a biopsy. The typical biopsy involves 6 cores, 6 needle sticks. For the purpose of this study, they did a 12-core biopsy, and the sensitivity of the biopsy in picking up cancer is going to be greater the more samples you look at. So it will have a greater sensitivity with 12 biopsies versus 6. 45% of these men with a PSA between 2.5 and 4 actually had cancer, 45%. Let's correlate the change in PSA in response to this biochemical stress test with the biopsy findings. Now, of the men with malignancy, the most important predictor was the family history. If you have a family history of prostate cancer, particularly premature prostate cancer, that suggests genetic anomalies in the androgen receptor. 83% of the men with cancer had a family history versus 17% without. Their PSAs were a little bit lower. Their percent free PSA was a little bit lower. Their testosterone level was a little bit higher. Their prostates were actually a little bit smaller. In the men who were found to have malignancy, their testosterone levels did not rise more than the men who did not have malignant tissue. But their PSA did. In response to 400 milligrams of intramuscular testosterone, the men who did not have prostate cancer, their PSA rose only 6%, from 3.2 to 3.4, a 0.2 increase. The men who did have a malignancy, it rose 1.1 points from 2.9 to 4, or 37%. So the rise in PSA in response to testosterone reflects the volume of prostate tissue. These men had malignant prostate tissue cells, and in response to testosterone, they released a lot more PSA. So this is actually being used as a biochemical stress test if you're not sure whether someone has a malignancy, whether they should have a biopsy or not. One strategy is to give them a high dose of testosterone, see what happens to their PSA. If it doesn't rise, they're less likely to have cancer as opposed to if it rises rapidly. Now, they found that a 10% rise in PSA had an 82% sensitivity, a 50% specificity, and a 56% positive predictive value in the diagnosis of malignancy. Now, this study was published and it was criticized by multiple other clinicians and researchers. First of all, it was a pretty small study, and their malignancy detection rate of 45% is much higher. In other studies, if you do 12-core biopsies on men with PSAs of 2.5 to 4, the malignancy rate is 25%. But the point is, if we give you testosterone and your PSA rises, that's a concern. Looking at this from the flip side, if you have BPH and a high PSA, and we give you Proscar to block the conversion of testosterone into DHT, your PSA will fall. If you have malignant cells and we give you Proscar, your PSA will fall, but not as much. And there's another biochemical stress test There was a study of men that had a PSA above 4 and 2 prior negative biopsies. Their PSA was still high, and the question is, should we do a biopsy every year, or can we ignore this? So in this study, they gave the men Proscar, and then they repeated the biopsy. In men whose PSA fell by 50%, none had cancer. In men whose PSA fell minimally, because the cancer cells were sort of out of control at that point, they were more likely to have malignancy. PSA change and prostate cancer risk with testosterone replacement therapy. 81 hypogonadal men treated at the University of North Carolina, and this was a retrospective analysis of the charts. They all had a testosterone level below 300, none with a history of prostatitis. If you have a urinary tract infection or prostatitis, your PSA will skyrocket. Your PSA will rise following a rectal exam. It's controversial, but it may rise after you ride a bike or after sex. So we have to keep that in mind in interpreting your PSA. There are many false positive causes for a high PSA. They all had normal baseline PSA levels. And you treat them with testosterone, 93% got the gel, 1% the patch, 5 got intramuscular testosterone. You follow them for 34 months and do a PSA level every 6 months. 90% of the men improved symptomatically, as you would expect, and 4 of the 81 men, or 5%, developed prostate cancer. In the entire group of 81 men, the testosterone level rose from 228 to 383, as you would expect. Now, the baseline PSA, the average PSA in all the men was 1.3. In those who did not experience cancer later on, it was 1.27. Those who subsequently developed a malignancy, it was 2.23. But the key parameter was the change in PSA in response to testosterone replacement therapy. The men who did not have cancer, their PSAs didn't change much. The men who developed cancer, their PSAs rose 1.8 points at 18 months, 3.2 at 3 years. There are various algorithms discussed in the literature, means of utilizing change in PSA to help us determine, are you developing prostate cancer, or is this a physiologic rise in PSA in response to testosterone replacement therapy? As a general rule of thumb, if your PSA rises by 1 point over the first year of testosterone replacement therapy, that is cause for concern. So if your PSA level is 2.5 and you have a normal rectal exam and we treat you and it rises to 3.6, and I say, gee, I think you ought to see a urologist and be evaluated, you say, wait a minute, Dr. Roberts, this is a normal PSA, I will say that that greater than 1 point rise is of concern to us. The effect of testosterone replacement therapy on findings in prostate tissue in men with late onset hypogonadal symptoms. 44 men presenting with symptoms of hypogonadism. Testosterone levels below 3, mean age 59, their PSAs were below 10. They all had a baseline biopsy. And in these 44 men, the biopsy was negative. There were 4 other men that were evaluated for the study, and they were not included because their biopsy was positive. So these men have negative biopsies. You do the baseline lab studies, the ultrasound for prostate volume, randomize them to receive every 2 weeks over 6 months intramuscular testosterone, a standard dose, or placebo. 21 of the men received testosterone, 19 placebo. Repeat the baseline studies at 6 months, including a biopsy, double-blind protocol followed. Serum testosterone rose significantly from 282 to 640 in the men receiving testosterone replacement therapy, but prostate tissue testosterone rose only a third. So it more than doubled in the serum, but it increased only by a third in the prostate. DHT rose from 28 to 47 in the serum, but prostate tissue content of DHT was unchanged. Both levels fell in the placebo group because the men were hypogonadal. Now here, this is the rise in testosterone in the blood. Not much is happening in the prostate tissue. This is the rise in DHT in the blood. Nothing's happening in the prostate tissue. So if we're giving you testosterone and your DHT levels rising in your blood, but it's not rising in the prostate, that would suggest that the testosterone is not going to have a strong stimulating effect on malignancy or conversion of normal cells to malignant. Prostate volume actually decreased slightly in both groups, a little bit more with placebo therapy. The PSA rose minimally from 0.97 to 1.1 with placebo. It rose more from 1.55 to 2.29 with testosterone, as you would expect. PIN, prostatic intraepithelial neoplasia. It doesn't mean you have cancer, but you have atypical cells. Again, this is akin to an abnormal pap smear in a woman. In the men who were treated with testosterone, 5 of them, or 20%, had PIN at baseline. Following 6 months of testosterone, that improved. Only 2 did. There was no change in PIN in the placebo group. New onset cancer, and I'm going to discuss that in a moment. The conversion of a normal biopsy to a malignant biopsy occurred in 10% or 2 of 21 men receiving testosterone, and it occurred in 20%, 4 of 19 of the placebo group. So the risk of converting a biopsy from normal to abnormal was greater in the untreated men than in the men who received testosterone, providing us with further reassurance. Now, did these men catch cancer or develop cancer? No. The false negative rate of a standard 6-core biopsy, it's going to depend on the population under study, but it's about 15%. I mean, if you have a small amount of cancer in a pretty big prostate and you take only 6 biopsies, you might miss it. The same situation occurs with breast malignancy. To really know, you would need to remove the prostate or do an excisional biopsy, a far more invasive procedure. So these men didn't develop cancer all at once. It was that they had malignancy and they were slowly growing, and then it was picked up. Testosterone replacement therapy in men with PIN. 75 men with symptomatic hypogonadism on testosterone replacement therapy for a year. Pre-testosterone, all of them undergo a PSA determination, a rectal evaluation, and a prostate biopsy. And if they had PIN, they had a second biopsy just to make sure malignancy was not detected. So none had no malignancy. Now this PIN is present in 0.5 to 27% of all biopsies, 86% of malignant biopsies. If you have PIN, you're at greater risk of developing malignancy down the road than if you don't have PIN. It's estimated 25% 3-year risk of progression to actual cancer. So 20 of the men had PIN, 55 did not have PIN. The testosterone levels were lower in the no PIN men. The PSA was actually a little bit higher. PSA above 4, only 6% of the no PINs, 10% of the PIN men's. The men with PIN were more likely to have a nodule or some abnormality on the rectal exam. So you're going to treat them all, PIN or no PIN, with testosterone for a year. At 1 year, you repeat the PSA, the rectal exam, testosterone level. You repeat the biopsy if the rectal exam findings change or if the PSA rose by more than 1 point. Now, testosterone levels rose to the same degree in the men with PIN or who were free of PIN. In the men with PIN, the PSA rose 0.33. In the men without PIN, it rose 0.25, no significant change. In the 55 men that did not have PIN at baseline, 4 underwent a repeat biopsy because their PSA rose by more than 1 point. None had cancer. So the cancer conversion rate was 0%. In the 20 men that had PIN, 2 had a repeat biopsy for a rise in PSA. Both were negative. 1 of 20 men, or 5%, had a change in the rectal exam and his PSA rose. He was positive for cancer. Another study showing that if we give you testosterone, we're not dramatically increasing your risk of progression to overt cancer. Actually, in the prior study, it actually would appear to decrease the risk. I'm presenting these studies so we understand that, yes, we need to be concerned about an acceleration in growth rate of pre-existent malignant cells, but it's not like 1 or 2 doses of testosterone is going to cause the cancer to develop rapidly and cause rapid metastatic disease. That is just not the case. That is wrong brain-in-the-box thinking. So to summarize, the testosterone in male genital urinary health, testosterone replacement therapy will increase prostate volume and PSA, will improve erectile function, will improve voiding function. Prostate cancer is common. It's real common. Heart disease is a little bit more common, but prostate cancer is the most frequently encountered male malignancy. The risk factors are age, family history, prostate volume, and other factors that we could go into. Pesticides, high estrogen level, diet all play a role. Low testosterone is associated with an increased risk, and it adds to the risk associated with PSA. So if your PSA is in the mid-range and your testosterone level is low, we would be a bit more concerned about you. It's not infrequent, even if your PSA is below 4, and it will be subclinical for up to 10 years. We suspect occult prostate malignancy if your PSA rises by more than a point, nodules develop on testosterone, the PSA does not fall in response to Proscar, the 5-alpha reductase inhibitor, and we also want to keep in mind false positive mechanisms for rise in PSA. You might have prostatitis that we would treat with an antibiotic. So testosterone replacement therapy is a risk to benefit decision. The risk can be attenuated if we keep the malignancy risk in mind and monitor you carefully. And now we'll move on to our final segment that covers routes of administration, and then I will summarize. Our final section discusses routes of administration of testosterone, and then I'm going to summarize. In the studies that I presented, testosterone may have been administered as a cream, a sublingual preparation, an oral therapy, an intramuscular injection, and several of the studies utilized pellet testosterone replacement therapy. Which is the best approach? Which one should we use? In this study, they took 27 middle-aged overweight men. You look at baseline testosterone, estradiol, SHBG, and percent-free testosterone levels. 11 received oral fat-soluble testosterone undecanoate. This is an oral therapy available in Europe and in the Far East, but not available in the United States. You repeat the levels at 6 weeks. 8 receive a standard intramuscular dose of testosterone enanthate, which is the standard route of administration in the United States. You repeat the baseline measurements at 1 week. 8 receive testosterone gel, 250 milligrams every morning. You repeat the measurements at 3 months. Now, with oral therapy, the testosterone level did not rise. It actually fell slightly from 14 to 13. With intramuscular testosterone, the level rises, and it rose significantly at 1 week from 22 to 41. With gel therapy, it rose from 15 to 28. Sex hormone binding globulin fell with oral therapy and with intramuscular therapy, but not with gel therapy. So the percent-free testosterone that you're concerned about, that you want to achieve, rose with intramuscular therapy, but not with gel therapy. Oral therapy is just not very effective, and that's been demonstrated in other studies as well. Another examination, 21 men undergoing testosterone replacement therapy. Baseline measurements to begin treatment with oral testosterone undecanoate, 80 milligrams twice a day. 9 received a single injection of intramuscular testosterone. You repeat the levels at 7, 14, 21, and 28 days. A third group received 600 milligrams of pellet testosterone, and you repeat the measurements periodically. Now with testosterone undecanoate, on these graphs, the normal range is 10 to 33. These are different patients showing variable rates of absorption and rise in blood levels of testosterone with oral therapy. Here's a single patient. Blood levels obtained on different days are quite variable. Oral testosterone undecanoate is not well absorbed, and it's variably absorbed. It's not a very effective approach. The levels peaked at 4 to 5 hours, but it were quite variable. Some were supraphysiologic, some were subtherapeutic. Back to or at baseline at 10 hours, so you have to take the stuff 2 to 3 times a day. The overall 24-hour mean level area under the curve was 12, just at the lower range of normal. Oral testosterone therapy is not very effective. Intramuscular testosterone. Here you see a spike in testosterone level up to 71. So it's clearly supraphysiologic. And then a gradual decline down in the low normal range. Now we want a physiologic level of testosterone. When we have a trough, we're not getting the benefits. But of greater concern are these peak levels. We're giving you more testosterone than you need. What happens then? Well, if you got too much testosterone floating around to be used, a greater percentage will be converted to estradiol. That's deleterious. Estradiol increases your risk of cardiovascular disease. A greater percentage will be converted to DHT, increasing your risk for prostate problems. So intramuscular testosterone it's effective, but I believe it has the the worse safety profile because you have problems with these peak levels. Mother Nature did not design us to have testosterone levels going up and down. We're supposed to have a steady level, characteristics of normal testicular function, so we have a problem with intramuscular testosterone. Conversely, pellet therapy provided the smoothest on-treatment values. After we place these pellets, they begin to dissolve. Your blood level rises, it peaks at 4 weeks, but it remains in the physiologic range, and it only gradually declines as the testosterone pellets dissolve. So you have physiologic, normal on-treatment values over a 4 to 6 month period, depending upon the number of pellets we place and the type of the pellet. Pellet testosterone therapy is clearly the most physiologic with respect to stable and beneficial on-treatment levels. Now, the peak and mean levels for oral therapy, the peak level was quite variable, varied within between individuals or within individuals. The mean level's kind of wimpy at 12. You got to take it twice a day. The IM testosterone, you have that problem with the high peak, and you need to have an injection every 2 to 3 weeks. Whereas with pellet testosterone therapy, the peak is not as high, the mean is better, and you only have to have the pellets placed every 4 to 5 months. Dihydrotestosterone, the normal range is between 2 and 6. With oral therapy, you're in the normal range. With IM testosterone, you're slightly above the normal range. With pellet therapy, you remain within the normal range. There was not a markedly increased conversion of testosterone to DHT. Same relationship with estradiol. Not much change with oral therapy, but then not much is going on. Look how high the estradiol level spiked with IM testosterone. Estradiol is deleterious. It increases our risk of cardiovascular disease. So we want to give you testosterone replacement therapy, but we do not wish to increase your estradiol level beyond the normal range. This did not occur with pellet testosterone therapy. You have stable physiologic levels, less chance of conversion to dihydrotestosterone, less chance of conversion to estradiol. Pellet release rate. Pellet therapy is commonly utilized in Australia and Europe. It was used frequently in the United States in the 40s, and then the patent ran out, and we lost interest in pellet therapy, and we gained interest in the new patentable therapies brought out by the pharmaceutical industry. This is data from an andrology unit in Australia that has an extensive experience with pellet TRT in men. 136 men undergoing pellet replacement therapy. They would place 800 milligrams, 4 200 milligram pellets. Now this is pure bioidentical crystalline testosterone. They heat it up and put it in a mold and apply pressure, and you get basically frozen testosterone. And they're about the size of a grain of rice. So they would put in the pellets, and then they would have you come back when you needed it. It was their practice for the patient to decide when they needed additional therapy, and they would always work in within a week. And typically the patients came back at 5 to 7 months saying, "Doc, I was feeling good. Now I got a letdown. I don't feel good. I need more testosterone." Invariably, your levels would be low, and this has been my experience as well. I put people on a regular schedule because I'm treating you for cardiovascular disease, not just to make you feel better, and I don't want your levels to fall, but my experience has been similar to this. Now, they had 775 implantation procedures over the 3-year period. Pellet extrusion, wiggling out from under the skin, occurred in 9%. 72 patients. In 44 of the 70 it was a single pellet. In 19 it was 2 pellets. 9 was 2 or more pellets. And these are the pellets. These are normal pellets here. And these are pellets that were extruded at varying time intervals following pellet implantation. You can see that the pellets are dissolving in a gradual, predictable rate. Now, 149 pellets were extruded. 112 were intact and available for analysis. The time of extrusion on average was 58 days. The weight was 129. Now, when you put in the pellets, they weigh 200 milligrams. And if you look at the weight of the pellet versus time after implantation, there's a straight line relationship. These pellets dissolve at a stable, predictable rate, 1.3 milligrams per day for each 200 milligram pellet. If you put in 4 pellets or 800 milligrams, that's going to be a testosterone release rate of 5.2 milligrams per day. The normal man makes 5 to 7 milligrams per day. So pellet therapy provides physiologic, natural and stable on treatment testosterone levels. The free testosterone level before they began pellet implantation was 21. The trough level right before their next was better maintained at 42. How frequently they needed to have their pellets replaced, those who did not have any loss of pellets, it was 175 days, the more pellets you lose, the lower your levels will be, the more frequently you would want to have the pellets replaced. Long-term experience in an andrology unit in Sydney, 973 procedures in 221 men over 13 years. The adverse event rate was 11%, the extrusion rate was 8.5%, bleeding was 2.3%, infection rate was 0.6%. Continuation rate, the decision by the men to keep up with pellet therapy, was 93%. And it was 88% after your first round, and your satisfaction, your wish to continue therapy, increased with subsequent rounds of pellet implantation. I've been utilizing pellet therapy for 5 years. Men greatly prefer pellet replacement therapy over injections, creams, sublingual or gels, because you feel good, because you have a physiologic persistent on treatment level. Now, what are all the methodologies that we could use? In the PDR, they still have oral methyl testosterone. If you take testosterone orally, it will be poorly absorbed. The testosterone undecanoate is fat soluble, so it sneaks around the liver and the lymphatics. It's not very effective. It's available in Europe and in the Far East. To make testosterone orally absorbable, the pharmaceutical industry attacked on a methyl group to make it absorbable, but the oral methyl testosterone goes through the liver, it causes inflammation, and all the side effects that we would see with anabolic steroid abuse in athletes. So no one should take oral methyl testosterone. It's carcinogenic. It's a stupid idea. Testosterone undecanoate is not available in the United States. It's available in Europe and the Far East. Sublingual testosterone mixed in with olive oil. You put drops under your tongue, and the advantage of this is it's incredibly inexpensive. It costs next to nothing. The problem is you have to take the drops 2 to 3 times a day. It tastes lousy, and you're going to forget to do it. So that is not a very successful therapy. We use it only when cost is a key constraint. The pharmaceutical industry or the compounding pharmacists can provide us with transdermal creams, gels, and patches. The adhesive on the patch is quite irritating. Most men will not stay on the patch. You have to put the gel on every morning. It's kind of messy, and you forget to do it, and you typically stop. So these are available. They're rather expensive, but they're not preferred. Intramuscular testosterone every 2 weeks is the standard used in the United States, and I think that's a dumb idea because you have the problem of the peak and the trough. I would predict that if we did a long-term study looking at outcomes and side effects, one group of men got pellet therapy, one group of men got IM therapy, the side effects would be much greater and the clinical benefits would be less in the men with IM therapy because you have the peak or trough problem. The preferred method, and the one that we're utilizing, is pellet implantation every 4 to 6 to 7 months, depending upon age and the type of pellets we use. The pellets available. I've been using pellets manufactured by a compounding pharmacist called Solutions Pharmacy. I've been using this for 5 years. I'm quite satisfied with these pellets. We place them every 6 months, in younger men every 5 months, and older men every 7 months. It is a compounded pellet, and it's not FDA approved. There's nothing illegal about compounded therapies, but it's not FDA approved. Thus, it doesn't have a drug code. Thus, you have to pay for it out of your own pocket, typically $260. Now, I find these pellets quite effective. I've been placing pellets, and I'm treating quite a number of men, and I have not had an infection, and I've not had any bleeding problems. I've had one man who's had multiple pellet implantation procedures, and he lost one pellet once. I will show you in a moment how we place these. We place them subcutaneously over the buttocks. This man was rather trim, did not have a lot of subcutaneous tissue. Now, after we place the pellets, we ask you to take it easy for a couple days. Don't engage in any exercise that might massage the pellets out of their subcutaneous placement site. Well, this man got his pellets, and he and his wife were kind of crazy about each other, and they engaged in a certain activity that we want to encourage, but not right after the pellets were placed, and one of the pellets migrated out. And that has been my only complication. The Australian group used pellets manufactured by a drug company, Organon. We're using the compounded pellets, and we've had far greater success than the other testosterone physicians in Europe have had. Now, new on the scene are Testopel pellets. The Testopel pellets, I've been using them actually less than 1 year. With the solutions pellets, I have a pretty good feel as to what your levels are going to be, how frequently we need to place the pellets. I don't have that yet with Testopel, but from my discussions with other practitioners, these pellets will need to be replaced every 4 months. They are FDA approved, they have a drug code, and your insurance company is more than likely to cover the cost. The cost of these pellets is $600, but the cost to your insurer of the other FDA approved testosterone preparations is much greater. So most of the time your insurance will cover it. But we don't know for sure, so our policy is as follows. If you're interested in testosterone replacement therapy, we go over the options. And many of you would prefer the Testopel if your insurer will cover it. So we will send in a prescription for Testopel to a specific pharmacy. That pharmacy will check with your insurer. They will contact you and tell you whether your insurance covered the Testopel or not and what your copay is going to be. And then you decide whether you wish to receive the Testopel pellets. If you say yes, you send in the money for the copay, and the pharmacy ships the pellets to us. We call you up and we put in the Testopel pellets. If you wish to have the compounded pellets, or if your insurer does not want to cover Testopel at a reasonable copay, then you come in and get the solution pharmacy pellets at your cost. The pellet placement procedure, the surgical procedure, is almost always covered in men. It is rarely, if ever, denied. Pellet placement. We create a sterile field, and these are what the pellets look like. These are the Testopel pellets. These are the solution pellets. The lighting's a little bit different. The solutions pellets are 200 milligrams. The Testopel pellets are 100 milligrams. That's the difference in size. What we do, we have you lying on your side. We prep your skin. In this picture, they use betadine. I use an alcohol swab. We create a sterile field, and then we numb up the skin. We use an awful lot of lidocaine, 2 large syringes. So we numb you up, and the only thing you really feel is the initial pinprick. Then we make a tiny little gash in the skin. It's about 1/3 of a centimeter. It's a very small hole. And then what we do, we place a trocar under your skin. Now the trocar is a metal tube, and we place in it a stylet, and it has a fairly dull, sharp tip. And I place it into the trocar, and then through the stab wound I've made, I push it into the subcutaneous tissue, and then I advance it this far under your skin, and then we're going to drop the pellets about 2 inches away from the stab wound. And what I'm doing, I'm not cutting and traumatizing, I'm twisting, and I'm really displacing the subcutaneous fat. I'm boring a little hole, so there's very little tissue trauma. Once I've advanced the trocar to the desired level, I take out the stylet and I put in the pellets, and then I push them through with another stylet device. So the pellets are placed 2 inches away from the stab wound under your skin. And then I will dress the stab wound with some betadine ointment, and I don't have to suture it because it's a tiny little stab wound, and I close it with steri strips. This is just another diagram. We advance the trocar, we put in the pellets, and then we deposit them about 2 inches away from the stab wound. What are the side effects and contraindications, the reasons not to carry out testosterone replacement therapy? Well, first of all, in patients with congestive heart failure, there can be transient fluid retention. Now, testosterone is great in congestive heart failure, but testosterone is anabolic. It wants to build things. And in preparation for building, your body may retain a little bit of fluid. So I've only had one patient in 5 years who experienced mild to moderate heart failure with testosterone, and he had a pretty bad heart to begin with. He did not require hospitalization. I just increased his diuretic. So if you have heart failure, you're not well compensated, I may increase your diuretic slightly as I put in the pellets, and that will not be a problem. Your red blood cell mass, your hemoglobin hematocrit, could rise into the pathologic range. Many of you have high hemoglobins because you have lung disease or sleep apnea. If we treat you with testosterone, which is anabolic, the androgen receptors in the bone marrow will be stimulated. You may make too many red cells. Your blood could become viscous. So I check your hemoglobin and hematocrit, and I'll simply say, give blood to the Red Cross. That's not a problem. The major concern we have that we've covered in the prior section, accelerated growth of pre-existent malignant prostate cells, and that's what we watch for. Precipitation of urinary tract obstruction. Testosterone will increase prostate volume slightly. It tends to improve bladder function more than it increases prostate volume, so urinary symptoms improve. However, if your prostate is so big that it's about to choke off flow of urine through the urethra, and we give you testosterone, we could precipitate urinary outflow obstruction. This has happened to me in only one patient in 5 years, and it's something we watch for. That man went to the emergency room, a catheter was placed, and he did fine. Spousal non-participation. If a couple are getting older, their hormone levels are low, they've lost interest in intimacy, and one man now has a normal testosterone, a normal libido, and his wife is not taking hormones, there can be a few conflicts. I've got a lot of really interesting stories of complaints I've gotten over the phone that I will not share with you, but I think you understand that problem. So we just have the spouse come in for pellets herself. Undesirable increase in estradiol. Now, men who are overweight with visceral fat have high levels of aromatase. Your baseline estradiol may be high, and if I give you testosterone, before you've had a chance to lose weight, you may convert it into estradiol. We can block the action of aromatase with a compound called anastrozole or Arimidex, so I can lower your estradiol. In fact, some men who are overweight, whose testosterone levels is just a little bit low, and their estradiol is really high, all I got to do is give you anastrozole, which will block the conversion of testosterone to estradiol. Testosterone will rise, estradiol will fall. If we're concerned about generating dihydrotestosterone, we can treat you with testosterone and Proscar, a 5-alpha reductase inhibitor. Thus, we will have less stimulatory effect on the prostate. We believe we will still get the beneficial effects of testosterone. We know that for a fact with respect to bone mineral density. We suspect we'll get the same benefits in the other organ systems. If you are diabetic and we give you testosterone and insulin sensitivity improves, we may need to back off into sugar medicines. In the literature, they talk about an aggravation of sleep apnea with testosterone. And I have not seen this, although I'm watchful. Actually, one would predict that testosterone would be helpful in sleep apnea. Almost everybody with sleep apnea is overweight with a high degree of visceral fat. Visceral fat is inflammatory. Not only does that inflammation go to the liver and cause insulin insensitivity, that inflammation goes to your brain and disrupts the biorhythms of sleep, which is why weight loss is helpful in sleep apnea. Testosterone promotes weight loss and downregulates inflammation, so we would predict that long-term testosterone will be beneficial, but we will be on the lookout for any short-term aggravation of sleep apnea. The approach to the patient. We need a rationale for testosterone replacement therapy. If your levels are low and you want to decrease your risk of diabetes or heart disease, and there are no contraindications, then testosterone replacement therapy with pellets makes sense. If you have cardiovascular disease, that in a sense is an indication for testosterone replacement therapy. Remember, in most of the studies, the men weren't selected for low testosterone, they just had heart disease. Now, if your heart disease is well compensated and your testosterone level is mid-range or high, then it wouldn't make a lot of sense to give you testosterone. But if you're struggling with heart disease and all other therapeutic efforts have been exhausted and your testosterone level is mid-range, then it would make sense to treat you. Now, it is rare that I see a new male patient with heart disease that does not have a low or a low normal testosterone. So it's usually not an issue. So most of my male patients I will treat with testosterone if they wish, because I know that it's going to improve their cardiac status and provide them with many other benefits. We do baseline levels of the hormones, and then I do peak and trough levels. Now, there's not a huge peak and trough with pellets, but there's some. So with the solutions pellets, I do my peak and trough levels at 1 and 5 months, with Testapel 1 and 3.5 months. If the baseline or on treatment estradiol levels high, I will treat you with anastrozole to blunt the conversion of testosterone into estradiol. I'm going to do a follow-up PSA at 5 months and then yearly. More frequently in some people, less frequently in others. It depends on what your risk is, in my mind, of prostate cancer. And we expect the PSA to rise, but if it rises a lot, if it spikes unexpectedly, then we need to investigate that spike further. I'll adjust the milligram dose of the pellets and the dosing frequency based upon how you feel and the blood levels. If there is fluid retention, which is unusual, we could use a diuretic. What can we do to decrease one's risk of prostate cancer? There's many nutritional supplements that have been discussed. Some are selenium, boron, diindolylmethane would make sense. If we're concerned about prostate enlargement, there are nutritionals such as saw palmetto, zinc, pygium, progesterone, essential fatty acids, and sernilton. And I'll check target labs such as lipids and lipoprotein A after your treatment regimen has been stabilized. Tiberius Reiter was a practiced medicine in London in 1967 and published this article describing his experiences with TRT. Now, his feeling at that point in 1967 was healthy men make about 20 milligrams a day, 7,300 milligrams a year. The standard at that time was to give far less, 200 to 400 milligrams a day in pellet form every 6 months. That was the unique dose for men that had been castrated. Replacement therapy should supply at least this amount, he felt, and he described the IDIT syndrome demonstrated by men with low testosterone. Impotence, depression, urinary symptoms, and thyroid hyperactivity. So Reiter would place 20 200 milligram pellets, 4,000 milligrams every 6 months. Now, his pellets were not as potent as our pellets. We would use typically 1,400 milligrams every 6 months, but his pellets did not release as much testosterone. And he treated 600 patients for many years. Careful genital urinary exam pre-treatment. He noted there was no symptomatic benefit for 2 to 3 weeks. That is true. It takes time for the pellets to begin to dissolve. None of his patients developed prostate cancer. BPH symptoms improved, as did mood and energy level. 1 in 300 of his patients developed coronary insufficiency, and they responded to treatment. I like those statistics. I like a therapy that doesn't seem to have a huge downside and has a significant upside, and which will decrease your risk of coronary insufficiency. Now, Reiter was taking care of patients in London in 1967. We're taking care of patients in North America in 2009. We're a much sicker group right now. So we're going to see more patients with prostate cancer, more patients with heart disease, but Reiter's experience was quite favorable, suggesting that we have a limited downside and a significant upside, and that is what we want in the care of our patients. And we would expect testosterone to be helpful in preventing cardiovascular events, because we know that testosterone is an independent risk factor for cardiovascular disease and underlies many of the other standard risk factors. If we treat you with physiologic levels of testosterone, the testosterone level will rise, the SHBG level is unchanged to decreased, free testosterone rises, estradiol is unchanged to increase, the ratio of free testosterone to estradiol, free testosterone to cortisol will increase, FSH unchanged to decrease, LH will decrease. Visceral fat decreases, muscle mass increases, percent body fat decreases, muscle strength increases, bone density increases. Lipoprotein lipase activity is differentially activated. It's activated in the liver so we can clear lipids from your blood, but it's inhibited in visceral fat, so we're keeping fat out of our bellies. Insulin sensitivity improves. Blood clotting parameters improve. Viscosity falls. Pi-1 activity decreases. Our ability to dissolve clots, fibrinolytic capacity increases. Eicosanoid prostaglandin metabolism improves. The prostacyclin to thromboxane A2 ratio increases. Systemic inflammation is blunted. Our arteries vasodilate, red cell mass increases, tissue oxygenation is enhanced. Our lipids, cholesterol, LDL, triglycerides, lipoprotein A decrease, HDL is typically unchanged to slightly increase, blood sugar control will improve. Immune parameters are affected. The deleterious Th1 immune cytokines, IL-6, IL-1 beta, CRP, all cytokines that are generated via nuclear factor kappa beta translocation of the nucleus are decreased. The Th2 anti-inflammatory good guy cytokines like IL-10 and IL-4 are increased. VCAM and ICAM are white cell adhesion markers elaborated by the endothelial cells that line our arteries over a plaque that help pull white cells in are decreased. Matrix metalloproteinase activity decreases, thus we are less likely to erode the fibrous cap over our plaques. We're less likely to have a clotting or unstable plaque event. Angina frequency and severity, nitrogen requirement falls. Treadmill time to ST segment depression increases. You have fewer episodes of chest pain, fewer episodes of ischemia. Symptoms of heart failure and claudication improve. Wound healing, energy level, sense of well-being improves. Depression is lessened. Your bones become stronger. Bone mineral density increases. Muscle strength, memory, erectile dysfunction improves. Bladder function improves. If you're interested in learning more about the beneficial effects of testosterone replacement therapy, weight loss, or any of the other integrative measures that we provide to our patients, please feel free to look at our websites, heartfixer.com, weightfixerohio.com. You can also read the book that I co-authored with Dr. Sinatra, Reverse Heart Disease Now, a patient manual of integrative cardiology. And don't stop there. I'm going to suggest that you read everything you can about health and everything that you can find about the diseases that you have. This is your responsibility. It is your opportunity. You can read alternative physicians. You can pay attention to integrative physicians like me. And I also want you to pay attention to orthodox physicians. Remember, notice I said orthodox, not brain in the box. Stay away from those guys. Learn everything you can about the pursuit of health, because this is your responsibility. Don't rely on me. Don't rely on your other physicians. Don't rely on the American Medical Association. Rely on yourself. You're the one who's going to determine your outcome. There's a great debate in our nation right now about the future direction of health care. The House just passed a bill to provide universal health care that's going to mandate that we all obtain insurance coverage. I don't think that's going to solve our problem, because we've lost our way with respect to health care in America. We do not have a health care delivery system. We have a disease management system. We're pretty good at it, but we're not focusing on the pursuit of health. We're focusing on the treatment of diseases one organ at a time. I may treat your heart with agents that compromise the health of the other organ systems of your body, and vice versa. I don't believe that our healthcare delivery system is going to be able to provide us with solutions and answers. I feel that the healthcare delivery system is a sinking ship. It's listing and it's headed towards a waterfall. Many of us have stopped bailing out the ship, and we've bailed out into our intellectual hovercrafts to see if we can find better ways to solve our patients' problems. I predict that 10 years from now, you will not be able to go in the hospital and get a second or third open heart surgery. I don't think everyone will be able to be treated with dialysis whenever they want. I don't think we will all get defibrillators. I don't think that we will be able to get a new joint when our old joints give out. I don't think that Congress, the President, the pharmaceutical industry, the American Medical Association, even if we work together, which we won't, are going to be able to turn this ship around in time. And I feel that it's incumbent upon all of us to make a commitment to pursue health. If you have a disease, learn all about how to deal with it, but above all, you must pursue health, because your health is your responsibility and it's your opportunity to achieve. And we think this is very important, and we appreciate your intention, and we hope we've generated in you enthusiasm for the pursuit of health. Thank you very much.